Welcome to the first panel of the summit. This group of 5 physicians will be discussing treating ROS1 cancer. I'll briefly introduce each of them, and then we'll have a panel discussion. We have an initial list of questions that were generated by the ROS1ders drivers based on things that come up frequently in our Facebook group. Please submit any questions using Padlet, as Amy suggested, and she will forward them to me. We'll address as many as we can in the time that we have. You'll note we only have 4 panelists up here at the moment. Melissa Johnson is on her way from the airport, having a flight delayed by a hurricane. So let's see, I'll start on the far right. Dr. Aaron Schenk is a physician scientist at the University of Colorado Anschutz Medical Center with an active clinical practice focused on patients with lung cancer. She leads multiple clinical trials investigating novel immunotherapy approaches for patients with lung cancer. Her lab investigates the lung cancer tumor microenvironment as a contributor to lung cancer progression and TKI resistance. Next to her is Dr. Jessica Lin, a medical oncologist in the Thoracic Oncology Program and the Henry and Belinda Termeer Center for Targeted Therapies at Massachusetts General Cancer Center in Boston, and an associate professor of medicine at Harvard Medical School. Her primary research focus is to develop novel therapeutic and biomarker strategies for patients with advanced lung cancers. Next to her is Dr. Tejas Patil, a thoracic oncologist at the University of Colorado Anschutz Medical Center. His clinical and research interests include new biomarkers and targeted therapies for lung cancer, molecular diagnostics, managing acquired resistance to TKIs, developing rational combinations of therapies, and novel clinical trials that address unmet needs in lung cancer. Next is on the next page is Dr. Amy Young, an assistant professor of molecular pathology at the University of Colorado Anschutz Medical Center. One of her primary areas of interest is in the molecular profiling of solid tumors, including lung cancers. And I'll read Dr. Johnson's just so I don't have to interrupt the group when she comes in. She is the director of the Lung Cancer Research Program at Sarah Cannon Research Institute in Nashville, Tennessee. As a medical oncologist, she focuses on new drug development for lung cancer patients. So please welcome our panelists. So first question, besides taking our medication on time, what is the one thing you wish patients would do that makes the biggest difference? And I guess we can just start over. I'll start with Aaron and we can move over. Put you on the spot.
That's okay, that's what I'm here for. Hi everyone, thank you so much for the invitation. I'm delighted to be here. Gosh, I think sometimes it's hard to think of one thing because I think each patient situation is different. I would say that one of the things I've noticed that has been the most helpful for my patients in the sense of just a feeling of well-being is trying to maintain, physical activity, being physically active, continuing on with your exercise program or starting one. I think that's made a big difference in just helping people. I like to talk about maintaining reserves because in situations like this is a marathon, not a sprint. And so maintaining those reserves by maintaining them through exercise, I think can be a big benefit.
That's really good advice. I guess I agree it's really hard to choose one thing, but one on the top of my list, one of the few on the top of my list would be to really don't be shy about sharing your thoughts with your doctor and the team in general. And those thoughts may have to do with what you're experiencing with the pill that you're taking or what your goals are in terms of getting to the next big event or general thoughts about your life, because everyone's experience with living with cancer and taking the treatment that they're on is going to be so unique and different. And unless you're very clearly communicating with the doctor, they're not going to know. And often there may not be one right answer, right? So if they're very clearly aware of what your goals are, they'll be able to really guide you in a personalized way. I also see that sometimes, patients and doctors are all humans, and sometimes patients are thinking, oh, we don't want to bother our team or we don't want to bother the doctor, but don't worry about that because that's what we are all here for. And so if it's even just a question that's briefly crossing your mind, tell your team, because then they can tell you, oh, this is something to worry about, or, oh, that's something we can just watch, and that way you're not losing sleep over it at night.
So as I was thinking about what others have said, I was trying to think of what is the one thing I would tell patients, and like every oncologist correctly pointed out, there's probably not just one specific piece of advice, but the one that comes to mind right now is to not underestimate the power of community, and to really, I think this room is a testament to the fact that ROS1 might be rare, but when you sit in a room and you see a lot of other people with ROS1, your stories start to feel less isolating. So I actually encourage every new diagnosis, like every patient with a new diagnosis of ROS1 cancer to actually participate in the ROS1ders groups. I think it's actually really helpful to get that solidarity from the community.
Hi, so as a molecular pathologist, I am involved in the diagnostic part of cancer, and I don't see patients clinically. I did get involved in the diagnosing of lung cancers because of an experience with my mother, who was a never smoker and was diagnosed with EGFR positive lung cancer. And that's how I kind of came into this realm. And from experiences that I had with my mother, I think that self-advocacy is really important, and really trusting your oncologist. And even in times of weakness when you're emotional and maybe what you're saying isn't something that your oncologist can directly address, but they're also part of that journey with you. So having an ally, even when you're just feeling vulnerable and frustrated, and having them on your side as your clinical caregiver is also just very powerful.
Thank you. So this time I'm going to start with you, Amy, because the question is about molecular testing. What do people need to know about molecular testing in cases when their treating physician is not a ROS1 expert?
And they already have the diagnosis
Why
of
don't
a
you
ROS1?
try it both ways?
Okay. So I think everyone in this room is really a really good demonstration of why, no matter what your background is, if you're a smoker or you're not, it's really important to get comprehensive molecular profiling of your tumor. That gives us a better idea of what's driving it and potential targets. And the targeted agents that we have to treat lung cancer is only increasing. So I'm sure many of you have heard of NGS, next generation sequencing. That's where we can look for a lot of different mutations in a lot of different genes in one time. Ensuring that your specimen is really well evaluated is going to be really helpful in terms of informing the oncologists about the potential mechanisms by which they can target your tumor. I am a strong advocate of academic centers and medical care. At academic centers, you have people like Tedros and Dr. Aaron Shank, who really specialize in what you have. And when you have something that's unique and challenging, you really do want the person who sees it all the time to be managing your care. That said, academic medical centers aren't accessible to everyone in the country, depending on where you live. And if you have to travel hours to see your oncologist, that's not necessarily the best care. And so in a lot of oncology, we talk about teamwork, and it really is a team. You have the medical oncologists and the thoracic surgeons and the social workers and the nutritionists and your primary care physician. So just making sure you have the right people on your team and having really good comprehensive molecular understanding of your tumor is just really going to help us optimize the care that you get.
You mentioned next generation sequencing. How many people in the room know they had next generation sequencing? How many people had molecular testing and you don't know what kind it was? How many people either didn't have molecular testing or don't know? A lot of you cheated.
Yeah, so I do have some slides about the different types of tests we can do, so I don't know if we want to save that for if we have time later, or...
Well, it turns out the way we have the table set up, we can't run the slides because it would be shining right in your faces.
Oh, okay.
So, so I'm sorry.
Okay.
Okay, so what does a patient need to know about the plan for the next steps when progression occurs during treatment? And Tejas, I'll start with you.
So I think progression is a very psychologically challenging time for patients, and it's always helpful to have a roadmap about what you're going to do. I generally like to think of progression as a event that we need more information to better understand what next steps look like. And that's information usually comes in the form of some kind of biopsy. In my practice, anyone with ROS1 lung cancer, I will get both a tissue and a liquid biopsy, and I can talk to you about what those mean, but one's a blood test and one's a tissue test. And I use this information to figure out if there are certain pathways that the ROS1 cancer is using to get around the current targeted therapies. And as you know, Jessica Lynn here has published a lot on this, and there are only a finite number of ways that cancers really can evolve resistance, and categorizing them can help understand whether a certain new clinical trial where there's a new ROS1 inhibitor, and there are several in development now, it'll help me understand whether that's actually the best option for you, or if there's some other new resistance pathway that's being turned on, whether a different trial or a different combination of treatments is appropriate. So I'm a big advocate for doing biopsies on progression. I think it's super important. It gives us a lot of really important information.
I would just add, I completely agree with that. And in patients in my clinic too, I almost always try and do biopsies when that's feasible. And we can talk a little bit more about that. Taking a step back, when your doctor tells you that the cancer has taken the wrong turn and that it's getting worse, I think there are, in my mind, 4 main questions, 5 I will say, that we should be asking. 1, where? Where is the cancer progressing? Is it in the brain? Just in the brain? Is it just outside the brain, or is it both? Because that matters in how you think about treatment strategies. 2, how fast is it changing? Sometimes there are situations where the cancer is starting to change, but at a very, very slow turtle pace. And that pace may be so slow that if you're really feeling well, and depending on what options are available, your doctor may recommend that actually we write it out just a little bit and monitor closely until the time comes where you actually do have to change therapy. So that pace is really important in helping determine the right timing of treatment switch. 3, how much progression is happening? And by that, I mean, is there just one or a couple places where cancer is progressing? Or is it in a lot of different areas, right? So we call, when there's only one or a couple areas where cancer is progressing, we call that by the complex term of oligoprogression, right? And that also drastically can influence our treatment recommendations, because if, for example, there's just one location where cancer's starting to grow, and everywhere else the cancer's doing really well on the current treatment that you're taking, then the doctors may decide, oh, you know what, this is a situation where we could really address that one area where cancer's changing using what we call local therapies. And that includes things like radiation, ablation, or even sometimes surgery. So that was 3, right? And then 4 is, why is the cancer changing? And that gets back to the question of, why is the cancer developing resistance to the current treatment that you're on? What's the biology underlying this behavior that we're seeing? Because that can also help us to choose the best next treatment option for you, and that's something we can delve into further. And I added 5 because, again, this gets back to the first question that was asked and the answer that I gave, which is 5, what are your goals? Because I think your goals and your preferences, of course, has to weigh into the next treatment decision as well.
This is an all-star panel. I really had to think hard about what am I going to add to what my colleagues had to say. I think there's one practical piece that I come across with my patient panels in patients who have ROS1 positive lung cancer. It's that, frequently folks travel elsewhere every so often to see me. And I would say, if you are in a situation where your local community oncologist is concerned about some changes on the scan, that's the time to reach out to your expert who maybe you've connected with previously to help sort of sift through these options and these possibilities that have been discussed.
I support that 100% because if your physical condition and your current life situation will allow for such travel and second opinions, it's always helpful to get different input, and different academic centers, even amongst us, between University of Colorado and Mass General, we have different portfolio of clinical trials, right? So in terms of researching potential treatment options, it's always good to present to different academic centers. Can we just go back to something that will tie together this question and your prior question, Janet, which is, let's get back to the question about the rebiopsies. So, let's say there is cancer progression and your doctor starts talking to you about a repeat biopsy. There are 2 broad categories that we talk about, right? Tissue biopsy and liquid biopsy. Can we explore that a little bit, and when we pursue one over the other or both?
You're prescient. That was the next question. Go ahead.
You might.
I was trying to make it more interactive.
I can, do you want to share a little bit since you're, really practically, a liquid biopsy has some strategic advantages. So what it is it's a blood test, and it goes to a variety. When we say liquid biopsy, really, it's a blood test. There's no biopsy, really, but it just sounds nice. It's a blood test, and it's looking for circulating tumor DNA in your blood. This gets sent off to a variety of different companies. Actually, some centers do it in-house, which is kind of interesting, but the big players are Foundation, Guardant. They're not the only ones, and I'm not doing brand favorites here. I'm just mentioning common ones. But honestly, any major company that has full next-generation sequencing capabilities. And what the blood test allows you to do is it allows you to ask some important questions. What are the kind of resistance mechanisms we're seeing? And broadly speaking, when we think about resistance in ROS1, although I will caveat that this is also true for ALK, this is also true for RET, this is also true for EGFR, but as a concept, these are true for anyone who's getting a targeted therapy. We like to break up resistances into what I call off-target, on-target, and then a third category, which I guess if we have time, we can talk about transformation. But let's start with on-target. So on-target's the most straightforward, and the way I explain it to patients is you have a lock and a key, and if you're changing the lock, the way the physical act of changing the lock, what happens is the grooves inside the lock are actually being rearranged, so the key doesn't slide in anymore. And if you can analogously think of that as happening in the cancer, that's kind of what's happening. So the cancer's evolving new mutations that are literally changing the grooves into where the drug binds. And just like a lock that's been changed, the solution for that is to get a new key. And so that's where new drugs in development are designed specifically to overcome some of those protein changes. So that's on-target resistance. Off-target's a little bit more complicated to explain. I'm curious to know what your examples are, but I've settled on, it's sort of like, basically what is happening is the cancer cell is recruiting other growth pathways that it has available in its toolkit to survive. And it's doing so because it's trying to survive in the presence of drug. And if we know what those growth pathways are, we can potentially offer treatments that block them. So that's off target, and I'm interested to hear other people's perspective on it. And then lastly, we're starting to see more and more of this concept of transformation. So everyone here who has ROS1 positive lung cancer presumably has non-small cell lung cancer. And every once in a while, patients will have that non-small cell switch to small cell lung cancer. And that's a very, I think, important event, one that we're starting to have more and more research on, because I think the therapies for that specific scenario look really different. So and so that's tissue biopsies, but liquid biopsies can cover all of this, with the sole exception of the last category, transformation. I don't think the tests are quite there yet to call a transformation event based on the blood. So I'll pause there, and I'm curious to know what my other panelists think.
So in terms of testing the liquid biopsy or tissue biopsy, generally what I observe among the oncologists on the Anschutz campus is that they'll generally order both. And sometimes that's kind of like a buffer layer in case maybe the tissue biopsy isn't sufficient for testing. You also want to see if it's, comparable. What's circulating in your blood is also what's, the tissue that they've biopsied. There are different ways to have progression, so it's not routine, but I would say it's not uncommon that the mechanism of resistance that's detected in your peripheral blood or on a blood draw might be different from the mechanism of resistance of whatever tissue it is that we're biopsying. So you can have different mechanisms of resistance, so the genetics of it can get really complex. So I think it's really nice when you can kind of correlate together both with the peripheral blood and a particular biopsy. And I just signed out a case last week where there were potentially 2 different mechanisms that we could target based on how the tumor was progressing, both what was detected in the blood and then the piece of tissue we happened to biopsy.
Just really quickly, I know there are lots of questions to get through. I just want to highlight that blood biopsies and tissue biopsies are very much complementary. One does not sufficiently replace the other. One question I often get asked by patients who are coming for second opinions is that they did have a blood biopsy. It was already done. It's done and over with. We don't need to talk about, another biopsy. But indeed, the blood biopsy that was done was actually not informative at all. If you look at the report, there's nothing there. No ROS1 fusion that was detected, nothing else that was detected. That does not mean that your cancer no longer has ROS1 fusion. It does not mean that a diagnostic repeat biopsy was done and that we didn't figure out what the mechanism of resistance of your cancer was. It just means that there wasn't enough cancer DNA being shed into your bloodstream for that test to be diagnostic. So often, actually, if you have just a little bit of cancer growth or in a limited area of your body, often the blood biopsy may not come back as helpful. So in those situations, it's important to advocate for asking about, is there a safe cancer spot in the body that could be biopsied for a tissue biopsy?
Yeah, I will say I kind of describe peripheral blood testing or liquid biopsy testing as kind of like the needle in the haystack, where the needle is like really tiny. It depends on how much you have of the tumor cell DNA you happen to have circulating in your blood, and you may have quite a bit and you may not. So if it's negative, like you said, it's you have to follow up with additional testing.
So to build on that, we are reading more and more about minimum residual disease, and patients who are NED occasionally think, well, maybe I should get tested to find out if it's growing. Can you address how often we should ask for retesting?
Janet, could you minimally resistant?
Minimal residual disease is a term for your treatment's been so successful that you can't detect any cancer in the bloodstream, and maybe it indicates you don't need further treatment.
I wish we were in that situation. That would really be fantastic. So when minimal residual disease, what I think about conceptually in the clinic is that I've started a patient on a targeted therapy, or really any therapy, and based on the scans, whether it's CT imaging, PET imaging, MRI, I can't really visualize, the scans can't really visualize a nodule or a cancer spot throughout the body. And that's a situation where the mass of the tumor, the volume of the tumor has gone down in such a fashion that, even with our very high resolution CT scanners that can detect something just a few millimeters, that hasn't quite gone away. Right now, we don't have the ability to test through blood or even through tissue, whether or not there still might be a few cancer cells present. I hope someday we'll have that technology to better understand, who might need intensification of therapy, for example, and who can we perhaps dial back therapy in some way. So the hope, the hope is that everyone has a great response to their therapy, and then sometimes I think the interesting questions are, what can we layer on top of my targeted therapy to help maintain this good response? And I think we get into that a bit later, but I'll stop there before opening up that whole different discussion.
So MRD, or minimal residual disease, is a complex concept actually that is evolving. Actually, if you think about patients who have early stage lung cancer, for example, after surgical resection, it's cured, it's gone, then it's worse to have MRD, residual disease, okay? In patients who have later, more advanced stage lung cancer where surgery is no longer an option and you're relying on pills to control the cancer, then currently we're using the term minimal residual disease almost to mean that there's been tremendous response to therapy, and so there's really minimal disease that's remaining, but we have to be careful in using the terms interchangeably. I think one practical question that comes up is, and I'm pretty sure we've all had patients in these situations where they've had such tremendous response to targeted therapy that even a PET scan shows no metabolically active disease that's left over. It's incredibly nice to see that happen. And then the question is, I am having some side effects on the pill. Can I stop it? That's a very practical question that comes up, and I'm curious to hear your responses. My medical recommendation right now is to continue on the targeted therapy as long as it fits into your life, because right now we don't have a good enough tool, like Dr. Schenk was saying, to really indicate that what we can't see radiologically truly means that the cancer is completely gone. And our assumption is that if you stop the targeted therapy, whether it be in a couple months or in 6 months or a year, the cancer will come back.
Can you also address dose reduction when you're talking on this topic?
Yeah, so I fully agree. The minimal residual disease concept is extremely complicated, and I 100% agree with Jessica that the terms are being used interchangeably, and there's actually really important distinctions here that sometimes get lost in the conversation. So the way I would separate this out is to think about two different scenarios. One is a patient who has early stage lung cancer. Let's say something is stage 1 or stage 2. They get treated with some combination of chemo and then surgery or whatever. And then after all of that's done, the question is, how do we know the cancer's really gone, right? That's one scenario. And there are different blood tests that are being explored in that scenario that are blood tests like we've been talking about, but the way they're designed and optimized are completely different than the liquid biopsy tests we were talking about in patients who have more advanced disease. Okay, so I really want you to separate those two as separate concepts. For the patients who have more advanced disease, and getting to your point about what do I do with this patient who has a PET CT that shows complete response. I actually saw that patient 2 weeks ago with ALK-positive lung cancer, and so that was fantastic. It was a very emotional visit. And the challenge I face there is we're going to be getting CT scans every 3 months for this patient, and if I couldn't see anything on the PET, what am I going to pick up on this CT scan? And why are we giving this woman ionizing radiation? What's the point of this? I would love a blood test instead of that CT scan. That's the best use case of this second concept of minimal residual disease. So again, I think this is an extremely complicated topic. I think the field is trying to parse out these concepts, but I really would think of two different scenarios, and when is blood test appropriate for the early stage, and when is it appropriate for the kind of monitoring stage. They're different kind of blood assays that are being used.
I will just say, as an aside, we do use minimal residual disease testing in other types of cancers, in hematologic or blood cancers, and BCR-ABL and CML. It's a different disease entity, but there are clearly defined metrics for for clinical decision-making based on minimal residual disease. So if you are at a cancer conference or something like that and you are hearing about MRD, it does have a role for some blood cancers. So it's just less well-defined in solid tumors, I would say.
I want to go back to a point that Jess raised. So talking about, I've been NED forever, should I stop taking my pill? Or I'm having horrible side effects, should I stop taking my pill? Can you address those two things?
Sure. So I think, was mentioned earlier, in the metastatic setting, what we understand is that, there are still residual cancer cells there, even if all of our testing can't see it. And when we release that break, when we take away the targeted agent, the cancer cell will have the opportunity to grow and spread again. And so my preference, like Dr. Lynn's, is to maintain patients on targeted therapies for as long as is possible and tolerable. And I would, in a situation like you're describing, Janet, I would, definitely do dose reductions. We can get, one of the nice things I think about being a thoracic oncologist is that we have so many different tools and we have a lot of ability to be flexible and personalize therapies. So sometimes it's, well, all right, well, maybe you just take, the lowest possible dose every day, or maybe you take a dose every other day, or maybe we find a really unique pattern that seems to work for you side effect-wise, as well as maintains a good response as we can visualize on the scans. But of course, there's always situations where, and I've ran into a couple of patients who've had really intolerable track-related effects. And they just can't tolerate the therapy. So we hold drug until our hands are forced.
We are at a time with ROS1 targeted therapies where once you start on a pill, hopefully you're on it for a good amount of time, right? So we're talking about a treatment that really, really has to fit into your life. It shouldn't be that you're fitting your life into the treatment. Your treatment has to fit into your life. And so if there are side effects that are impacting your ability to pursue the activities that you want to pursue, to work full-time, if that's what you want to keep doing, to go on vacations, trips, whatever it is, then I would not be worried about or scared of dose reduction. We often recommend dose reduction of various targeted therapies, and going down on the dose of the drug does not mean that there will be higher chance of cancer progressing on the next scan. We often do it, and we often also institute dose interruptions when you're getting procedures, when you're getting radiation. If you just need a little break, going off of the pill for a week or so is okay. So, obviously, every individual situation is different, so talk to your doctor about it. But I would encourage everyone to not be kind of scared totally of that general concept.
If I can circle back to some of the earlier themes about, all of us up here want to help you, and sometimes it's really hard to meet your goals if we don't know what they are. So if you are really concerned about a side effect profile or dose reduction, just be open about it, and we can talk about what are the strategies available moving forward. And I think it's also an important corollary, if you feel like your concerns and needs aren't addressed, it's okay to seek out a second opinion. It's okay to go talk to someone else, to try to find someone who, maybe just quite honestly has more comfort with these therapies and understanding, the safety margins and the profiles and the data and how can we best adjust to meet your goals.
I could just address that too. So if someone is having progression but they can't get to a ROS1 expert, what are some of their options? They ask their local oncologist to reach out to you?
That's what I frequently do, and I try to keep pleasant and friendly relationships with all of the local community oncologists here in Colorado, because I think for one practical purpose, it's nice having relationships with doctors, and then if there are therapies that we have to give more locally, like specifically I'm thinking about chemotherapy, rather than having a patient drive from Casper, Wyoming, all the way down here, that's not practical. That's a 5-hour plus drive. Having it done locally with an oncologist that I have some relationship with, I think is always the best scenario. There are a variety of second opinion programs that are in place. I know Massachusetts General has them. We have one at University of Colorado. But I want to get back to that TKI point earlier. I think the ROS1 community in particular is at a very unique space relative to other oncogenes, because I think the TKIs that ROS1 patients have available to them have such different side effects, and it is very different than what we see in the ALK positive community, the RET positive community, or even the EGFR positive community. There is a lot of difference between a drug like repotrectinib, crizotinib, and lorlatinib. They have extremely different side effects. And I don't think other communities really have this kind of TKI choice. And so one thing to add to the side effects is also don't be afraid to switch TKIs. I've had patients who could not tolerate entrectinib switch to lorlatinib and have done really well with that. So that's another option too.
I guess answering your, going back to your question, Janet, about asking your doctor to reach out to one of the ROS1 experts, short answer, absolutely yes. We're a very friendly community. We want to help each other out, and we want to help patients even in areas where, we cannot reach ourselves. And so definitely, and please spread this within your group as well for those of you who couldn't attend. We are all here.
I would much rather spend a few minutes, answering a very nice email or calling someone so that someone can get the right therapy for them. That's a win in my book, and then, just building that relationship too, so that they know they can reach out to you with future questions about patients with lung cancer.
So you mentioned we have a variety of TKIs, but sometimes you run out of options. What can you discuss chemotherapy, when and where it fits in the treatment path?
Chemotherapy has gotten a very bad reputation now because of the successes that we've had with targeted therapies, and often we have patients come for second opinions actually once the targeted therapies have kind of run their course, and I can feel the palpable fear and worry about chemotherapy among the patients and caregivers. And so actually what I do when I'm meeting a patient who's newly diagnosed with ROS1 lung cancer, even from the get-go, is that I set the expectation that chemotherapy will end up being a tool that we reach for at some point. It's more a matter of sequencing and time. And so absolutely, chemotherapy is one of those things that's been around for a long time, but it can still be quite useful in getting that cancer to behave again and getting us more time, during which time more clinical trials may become accessible or new therapies may emerge. And so if targeted therapies have run their course, absolutely chemotherapy will be one of the options that your doctors will discuss with you. These days, we have much better supportive medications and regimens that we employ as chemotherapies are administered in order to ameliorate the side effects that come with chemotherapy. So definitely talk to your doctors about that.
I'm going to take this opportunity to ask my esteemed colleagues a question. So would you consider layering on chemotherapy with the first start of a TKI, sort of like we're doing in the EGFR space?
Why would you do that?
Make it easy for them, why don't you?
Why would you ask this question?
Because I'm here with really smart people, and I'm interested in this clinical question's going to come up. So
I will take it.
Okay.
I will bite the bullet. No. I will explain why. Because, by the way, can I just do a brief check? We're at the 30-minute mark. Is the level of discussion that we're having here appropriate, like at a good level for all of you? Is it way over your head, too little? Okay, good. So what Dr. Schenk is referring to is that in another molecular subset of lung cancer with EGFR mutations, which occurs in about 10 to 15% of patients with lung cancer, there's recently been a clinical trial that compared EGFR targeted therapy called osimertinib used by itself at initial diagnosis as first therapy, compared against osimertinib plus chemotherapy, and they asked the question of which one's better in terms of effectiveness. And there was a superiority with the EGFR targeted therapy combined with chemotherapy in terms of the length of time before cancer started getting worse again. And so the EGFR targeted therapy plus chemotherapy, that combination regimen is now approved by the FDA in the United States to be given as initial treatment for these patients. And so some of us are asking, well, what about in other molecular subsets of lung cancer that we think are biologically similar to EGFR lung cancer, ALK lung cancer, ROS1 lung cancer? Should we be employing a similar paradigm? The reason my answer is no is because I think when we think about layering on something on top of a pill, what really matters is how much are you getting out of the pill itself? And in every subset of lung cancer, what the pills are achieving is different. Meaning, one, how much is the pill doing in terms of effectiveness? If we look at ALK lung cancer, lorlatinib, which is an ALK pill alone, it gives a median progression-free survival, meaning on average, the length of time before cancer progresses again, over 5 years. And so you could say, well, in that case, do we really need to subject patients to chemotherapy cumulatively with side effects to boost the efficacy? Specifically going back to ROS1 lung cancer, we are in a very unique time with the ROS1 targeted therapies. The landscape of ROS1 inhibitors is rapidly shifting. And what we are talking about today as standard initial therapy to use may be very different from what we're talking about in just a short few years. And the ROS1 inhibitors that we're using right now as standard initial therapies do come with side effects, right? So we have 2 ROS1 inhibitors that are considered first-generation ROS1 pills, the earliest developed ROS1 pills, crizotinib and entrectinib. We have 1 FDA-approved ROS1 inhibitor right now that's considered next-generation, repotrectinib. And so these all, in separate clinical trials, showed different lengths of time before patients hit that progression time point. So repotrectinib in a phase 2 trial, that PFS, progression-free survival, median was a little over 35 months. With crizotinib in a complete separate trial, so you can't compare these data, head to head. Crizotinib in a completely separate trial with a different patient population, that median length of time before cancer progression occurred was around 19 months. With entrectinib, it was, depending on which publication you look at, somewhere between 15 and 19 months. And so you have differences in efficacy and then very unique side effects with each drug, where I do worry, both from efficacy standpoint, I think that we're going to have soon more next-generation ROS1 inhibitors that may achieve a deeper and longer duration where we might not need chemotherapy. And 2, from a side effect profile, I think the pills that we have cause enough side effects where I don't know that adding the side effects of chemotherapy cumulatively right now is worth what we get. Sorry for that long-winded answer. I realize that was not very articulate, but I just wanted to walk you through the thought process.
No, it's really great. Yeah, so I'll answer it much shorter. I will not use chemotherapy upfront for ROS1 positive lung cancer until there's a trial that shows that there's something of benefit here. And to Jessica's point, the biggest issue I see, it gets to what I raised earlier, in that ROS1 patients have a variety of targeted therapies available to them with very different side effects. That is not the situation the EGFR community finds themselves in. They are almost all using osimertinib as a frontline treatment. So you can then do a study where you compare the first best TKI to first best TKI plus chemo. But in the ROS1 community, we have repotrectinib as the new kid on the block. There's taletrectinib that's in development. Nuvalent has a clinical trial that's in development. Very soon, you're going to have 3 or 4 next-generation drugs, each with a little bit of a different side effect profile. And now you're talking about adding chemo. So to me, that feels like taking a step back in time and pulling out something old. And the fundamental question that even the FLAURA2 data never really answered is there a benefit to doing upfront osimertinib and chemotherapy, or osimertinib, waiting till you progress and adding chemotherapy at the tail end? Which sequence is better? That was actually not answered in that study. And so until there's some equipoise in that management, I'm thinking that the most important thing for patients is quality of life and efficacy. And I think I can get really good efficacy with the current ROS1 treatments. A lot of it's going to be side effect navigation. That's really, I think, the most challenging part in ROS1 management, is just because these drugs have really different effects, and they have really real trade-offs. So for example, crizotinib is a fantastically well-tolerated drug in relation to some of the other choices, but you lose the CNS control, and that's a big deal in the ROS1 community. And so navigating these trade-offs is actually much more nuanced and requires a lot of finesse than I think any other oncogene subset that I'm aware of right now.
And Tejas, I just want to confirm, when you say you would not use chemotherapy up front, you're talking stage 4 only, correct?
Stage 4 lung cancer, yes. That's a
Okay.
good follow-up, thanks.
So say somebody has progressed and none of the TKIs seem to be effective, so they try chemotherapy. Would you ever re-challenge a TKI after someone's gone on chemo?
So the re-challenge meaning that you've done your TKIs, then you've done a little bit of chemo, and now you're looking at some options after that, and would you ever go back to the original TKI? The short answer is yes, but I have to say the duration of response is not very long. And so I use it mostly as a pinch to get the patient to some other therapy and get some disease control in the meantime. I don't know what everyone else's experience is here.
Yeah, so going back to the same old TKI where there was cancer progression before, my default answer would be no, unless there's been like several years that have passed since that time of exposure, and the patient has not in that time interval, the cancer had not seen any ROS1 inhibition. So let's say somebody was on, just for the sake of simple explanation, if somebody was on crizotinib 9 years ago and then has been on chemotherapy and other non-ROS1 targeted therapies in that time period, and we need something, I might try it, but my default answer is no. But I do often, in somebody who has brain metastasis, for example, that are responding to a brain-penetrant ROS1 targeted therapy, but had progression in the body and needs to go to chemotherapy, for example, I will often keep the brain-penetrant ROS1 targeted therapy going on top of the chemotherapy to maintain that brain disease control.
That's a great theme too, timing. So sometimes, we come back to a therapy, especially if enough time has passed since it was last seen by the patient. That's true for chemotherapy too, occasionally, where someone maybe had a great response to a certain set of chemotherapies, transitioned to something else, maybe it was a clinical trial, and that's often a time where I would consider, what were the therapies that were effective previously, and can I think about, is it safe, is it feasible, does it make sense to go back to those?
Well, since I clarified stage 4, I'm going to complicate things now. In the past year or so, we've had several people join the group who were diagnosed at stage 3. And as you know, the standard of care is chemotherapy plus immunotherapy. And sometimes they get adjuvant TKIs given after they've had their curative treatment. So can you discuss the kinds of immunotherapy, and if it's ever used for ROS1, is it appropriate to use it for stage 3? And Erin, I'm looking at you.
Thank you. How much longer do we have? I could talk about this for a very long time. So right now in my clinical practice, if patients have a ROS1 positive lung cancer, the immunotherapies that are currently available to us clinically, and so these, you might have heard of these called checkpoint inhibitors. These are special medicines that block certain pathways that inhibit the immune system. Based on the information we have, in some of its retrospective studies, meaning we've looked at the history of patients with ROS1 lung cancers who received immunotherapy, and also pulling from other patient populations with a driver oncogene, we have a pretty good sense that these clinically available checkpoint inhibitors, these immunotherapies, they don't serve a benefit for patients with ROS1 positive lung cancer. And so if someone is stage 3, where we do have many options in how we approach them, in my clinical practice, I would not incorporate immunotherapy into the treatment approach. And I think it's 2 major reasons. Number one, There's a lot of, there's a significant amount of data, which some is prospective, meaning some have been clinical trials that we've done in other oncogene-driven lung cancers. Some is retrospective, us looking at the history that tell me that overall, I don't expect to see the benefit that you should receive from immunotherapy. And number two, honestly, I'm kind of worried that I will give the therapies available for that earlier stage cancer, whether it's chemotherapy plus minus radiation or surgery. And it's already, unfortunately, it's already happened clinically where a patient has a recurrence after their initial curative intent therapy, meaning if I had given them immunotherapy, it would still be in their system. And then if I need to start a targeted agent, that overlap we found can be really toxic. So it's an efficacy issue and a safety issue in my mind.
I agree. I also do not, it's always a lengthy discussion because the immunotherapy drug that we're specifically talking about for patients who have stage 3 lung cancer is durvalumab. And technically, the clinical trial that looked at durvalumab after chemotherapy and radiation in stage 3 lung cancer that's not resectable, it didn't exclude patients that had ROS1 lung cancer. But that said, for all the reasons that Dr. Schenk so nicely outlined, my recommendation is not to do durvalumab or immunotherapy after chemoradiation. May I ask the question, may I take the question and take it back to stage 4 setting and just ask the panelists, for patients who have stage 4 advanced lung cancer, one question that I sometimes get asked is, after targeted therapies, when they do need to go to chemotherapy, would you recommend giving it together with immunotherapy or not?
No, I wouldn't recommend immunotherapy outside of a clinical trial. And the reason is that while there's nothing specific in the ROS1 space, there have been two, actually, this has been studied in the EGFR mutant lung cancer space. There's actually 2 phase 3 randomized clinical trials that have looked at this in the EGFR mutant space. So what they did was they looked at patients who had progressed on osimertinib. One group was randomized to chemotherapy. One group was randomized to chemotherapy plus an immunotherapy. And there were 2 separate trials that used 2 different immunotherapy drugs. And they were negative studies. So the immunotherapy didn't do anything. So now, using that data, but in some ways, they didn't even have to run this trial. There was already a lot of retrospective data that showed that this wasn't going to work anyways. But we have prospective data from those 2 trials. We have a lot of retrospective series. There's a very nice one that came out of France called the Immunotarget retrospective series that I oftentimes reference, where they looked at like a lot of patients in the country of France and who received single agent immunotherapy, and you can see the response rates were oftentimes in the order of like less than, I think, 20% at most, and most patients progressed in 2 months, which what that means practically for you is that your next scan showed a progression event, right? So you just wasted that 2 months doing a therapy that wasn't doing anything. So no, I wouldn't use immunotherapy. Now, when I say immunotherapy, it gets back to sort of what I was drawing the distinction earlier with MRD. We have to be really careful what we say when we use the word immunotherapy. We mean immune checkpoint inhibitors, a drug like pembrolizumab or nivolumab, PD-1, PD-L1 inhibitors. We do not mean some of the newer immunotherapies that are in development, like dendritic vaccine therapies, T-cell engagers, bispecific engagers, CAR T. That is also in immunotherapy, but is very different.
Well, so some people come into the group and their doctor did not know they shouldn't give immunotherapy to ROS1, or they got stage 3 standard of care with immunotherapy. How long do you recommend that a patient wait to start a TKI if they have received immunotherapy?
It depends on the urgency of the need. So what I mean by that is someone really sick because of cancer progression, or is the cancer active in really precious real estate, such as the brain or maybe the spinal cord, where you really need an effective response as soon as possible. So I think that comes into play when you start. And sometimes I think patients are also very nervous not receiving therapy and waiting for that immunotherapy medicine to sort of what we call wash out of the system. So I think it just takes a good detailed discussion with your doctor about, here are the risks and benefits, here's the potential toxicities with this overlap, here's how much I think you really need it, how can we find a way forward? I think there's some, I don't know if they've been expert consensuses or basically people on stage giving their opinion or other information, but I think it's about 6 weeks is recommended for that washout period. But again, it's highly variable based on, again, the clinical need and how concerned someone is.
Has anyone in this room had that experience where they initially got immunotherapy and then found out the ROS1 was, okay. Yeah, it's actually it actually still happens pretty commonly, and I'm sure if you haven't had that experience, you might have heard of somebody where, and just to take a step back, the reason this question is asked and the reason this happens is because when we do biomarker testing, not every result comes back at the same speed, right? So often when the doctor orders the right biomarker testing for new diagnosis of lung cancer, the PD-L1 testing result, which is what matters for decision-making about immunotherapy on top of the next generation sequencing, PD-L1 result comes back often the fastest because it's quick to do, and you can speak about it a lot more. So the PD-L1 testing comes back, and doctors see a very high level of PD-L1, like 90%, 85%, and then they say, okay, you know what, let's go with immune checkpoint inhibitor. And then the next generation sequencing result may come back 2 weeks later, 3 weeks later, sometimes even 4 weeks later, and then oops, there's a ROS1 fusion. We should have treated with ROS1 targeted therapy. And the reason we care about the sequencing is because over the recent years, what we've learned is that often, not always, but often, when patients get exposed to these immune checkpoint inhibitors like pembrolizumab or nivolumab, and then are found to have a target in the tumor, and so switch to appropriate targeted therapy, there can be increased risk of toxicity. So sometimes we see very severe liver injury. Sometimes we might see very intense rash to the point where you need to be hospitalized for intravenous medications. Sometimes we see very bad inflammation in the lungs to the point where you require hospitalization or sometimes even intensive care unit stay because of the oxygen requirement. So this is not a small risk that we're talking about. Now, there is some variation in terms of whether that increased risk occurs and to what extent, depending on the particular targeted therapy we're talking about. So some of the side effect toxicity profile that we see is targeted therapy dependent, but because of these situations that we've come across, the lesson learned is to hold off on introducing immune checkpoint inhibitor until you're absolutely sure that patients are not going to need to go on targeted therapy. So if somebody needs to go on a treatment because of symptoms, while the biomarker testing is pending, we might start with chemotherapy first and then switch to targeted therapy. And then in terms of the washout, we don't even know if the appropriate washout of the immune checkpoint inhibitor before somebody starts on targeted therapy is going to be the same for every pill, right? It might be different for different medications. I think the safest thing to do, like Dr. Schenk said, is to let the system cool down if we can afford it. Generally, I prefer at least 3 months if possible, but we may need to bridge during that time with chemotherapy if needed.
Do you want to speak about the workflows of the PD-L1 and GS?
Yeah.
Because I think that's really a fascinating
So
story.
in terms of diagnostics and molecular testing, we have a lot of different tools in our tool bag in terms of how we get that information to provide it to the oncologists. And in an ideal setting, we would have plenty of tumor to test, and we would do full next-generation sequencing on everything and just have a comprehensive answer. But the practicalities of it are sometimes we have a very scant specimen, or sometimes the patient is very sick. So, Dr. Patil or Dr. Schenk will reach out and say, we do want full molecular next-generation sequencing on this panel, on this patient, but they're really sick, and they have a high pretest probability of having EGFR. Can you just look for that? So that would be a test that I could do potentially on the same day and get that result to them so that treatment could start sooner if it's positive, rather than waiting a few weeks or a week and a half or more for a full comprehensive panel. PD-L1 testing is not a molecular test. It's what's called IHC. It's immunohistochemistry, and it's taking the specimen and and at doing a stain like on the slide. So we're not actually extracting DNA or anything like that. We're just labeling the tumor cells on the slide. So the turnaround is a lot faster. I know that the cancer biology and diagnostics are really, really complicated. I'm happy to stay after if anybody has specific questions for me. And I don't know, I'm also happy to share my slides after the fact. I don't know if we can pull the tables apart and I can just kind of show the slides to kind of walk through it, because I know it's really complicated. But when we think about diagnostics, we're thinking about kind of the cellular level, and then the chromosomal level, and then the DNA level, and then also the RNA, and ultimately the protein level. So there's all these different ways that we can be informed about what is going on genetically with a tumor cell. So I hope hope that was helpful.
That was great. And I would just add that what is considered ideal testing to be done on your biopsied sample will be different at different points of your cancer diagnosis and treatment. And so then that just adds more complexity. So I would just encourage all of you to talk to your doctors about that. Like, what kind of testing do I need at this stage? Do I need this one? You know, talk to your ROS1der community, get second opinions.
So I have a question related to that came from the audience. If you do have progression in just one area, should we have a biopsy, or is it feasible to just go ahead and treat it?
I think it's a very case-by-case situation. In general, the answer is treat it, but I think it can also be informative to know what the resistant clone is. So for example, if it's a supraclavicular node, which is an area that we can probably get to really easily, you don't have to go under conscious sedation, just general, like, local anesthesia and a simple FNA or even a biopsy there. And if we can actually get that material, it can be helpful for two reasons. One, it can potentially shed light into why there was that progression event in the first place. So it gets to that, are we dealing with an on-target resistance category or an off-target resistance category? That's one. But two, if in the future there's more kind of urgent need for tissue for the purposes of a clinical trial, well, you have a tissue sample sitting right there. So I think that there's some strategic reasons. Not in every patient is this the right decision, and sometimes we have to take the patient's own anatomy and the relationship of the lesion in question to other structures in the body to make that judgment call. So for example, if the supraclavicular node is too close blood vessels in the neck, then no, I'm not going to put a patient through a biopsy. I would just treat it with radiation. Or better yet, if it's really the only site of progression, talk to your ENT surgeon and see if you can do a supraclavicular nodal dissection and just have the whole thing come out. So, and that's speaking on a patient I've done that for recently. So I think there are ways to get creative here. And I don't think there is going to be a one-size approach here. I think every patient's going to have a one-by-one approach.
So here's a general question. How do you help your patients choose between an available clinical trial or an FDA-approved drug when they need a new form of treatment?
I think it's being about transparent around the risks and benefits of both. Oftentimes when I am taking care of patients and they've been on standard of care or targeted therapies that are, just widely available, they've known what cancer care is like through that lens, meaning maybe they come once every 3 months for blood tests and scans and a visit. And I think it's important to talk about how the logistics change when you're on a clinical trial, because often you come to our site more frequently. There's more frequent testing. There are more frequent, doctor visits and interfacing with the cancer care team. So I think that's one of the things that's always important to highlight. But then I think, again, like you're hearing a lot from us, each case is very individual. There are definitely times where I say to a patient, I really think, I feel very strongly about this clinical trial for these reasons. I think we should really consider it. Or there's also situations where I say, actually, I think what I can get you standard of care or, compassionate access would be the better option here compared to a clinical trial. So again, it's weighing the pros and cons. I think often the major things making this decision are, number one, do I have a good reason to choose one thing over another? Meaning, is there a clear resistance mechanism? Is there a clear change that I can target either through a clinical trial or some other therapy that I have off the shelf? And then number two, it's, how much is your life going to be bothered, and is that an acceptable level of change to quality of life, change to interfacing with your cancer team that's acceptable?
Okay, so a specialized case of that, brain mets. When initially all we had was crizotinib, you stayed on crizotinib and we radiated the brain mets. Now we have a lot of TKIs that get into the brain. If somebody has been doing well on crizotinib or some other TKI and the cancer has not yet gone to their brain, and then they develop brain mets, when do you decide to radiate the mets versus switch a TKI?
In somebody who's been on crizotinib and having CNS progression or brain progression, I would actually recommend switching to a brain active pill as opposed to doing radiation, because there are such pills that are available both in terms of FDA-approved therapies and on clinical trials. Radiation can still be used later on. It's not like you're omitting radiation, right? If you still have progression at some sites in the brain, even on a brain active ROS1 targeted therapy, radiation can still be used. But there's something to be said for trying to defer it. Focal radiation, often doctors use the terms like gamma knife or SRS or stereotactic radiosurgery. Those are far, better tolerated than whole brain radiation for sure, but they're not risk-free, right? Especially in this era where we have brain active treatments, we are actually seeing more and more of what we call radionecrosis. And some of you may have heard this term before from your doctors. And this is where there's injury to the brain tissue surrounding the area where there was a cancer spot that was radiated before. So because some of the normal tissue is also going to be hit with the radiation. And we're seeing more and more of that with patients that are on brain active therapies. So I think it's good to be able to defer the radiation if it's safe to do so and if there's a good alternative pill option. So I would switch.
Agree.
Well, that was easy.
Isn't it so nice when multiple doctors in the room agree on the answer?
Let me ask you a provocative question then. Patient shows up with newly diagnosed ROS1 positive lung cancer. We know there's a high incidence of brain mets at diagnosis in this patient population. Let's say this patient has 40 brain mets at the time of presentation. Would you start them on a CNS penetrant drug and defer radiation, or would you give radiation up front for this patient? So now I'm choosing a question that might split the group a little bit. So
Are they symptomatic?
let's say yes.
Well, I think there's a couple options here. If they're symptomatic because of swelling due to the metastases in the brain, sometimes there have been occasions where I've given steroids, which help reduce the swelling, as well as targeted therapy, as well as covering my bases and sending them to my colleagues in radiation oncology simultaneously. But in general, Dr. Patil picked out a high number of brain metastases where a radiation doctor, in the absence of an active medicine that can attack the brain metastases, where the patient would have to get something called whole brain radiation therapy. And that has a significant burden of side effects, especially in patients who we anticipate will hopefully do well for a longer term thanks to the targeted therapies. So in a situation like that, I would try to defer radiation. I would even try a little steroid if possible, to reduce some side effects. But occasionally, there may be 1 or 2 brain metastases that might be larger, more likely to be causing any symptoms a patient might be having, where the radiation oncologist just go after those lesions initially and see how well the targeted therapy works.
Yeah, if it's many spots and but all are pretty small, I would still be inclined to start with a brain-active ROS1 inhibitor. If you ask me about a symptomatic 3-centimeter brain met, my answer would be different.
Probably be surgery at that point, yeah. The reason I asked this question, I would do the same thing too, but I think this is an emerging concept in the field of whether we should treat up front with stereotactic radiosurgery for patients who have very high volume brain metastases, or whether we can do what's called CNS downstaging and start with a brain penetrant drug. I think it should be, it goes without saying that in this specific scenario I outlined, crizotinib is never the right answer. So if a patient has 40 brain mets, no doctor should be prescribing crizotinib. And even though it's in the NCCN as a category 1 recommendation, this is actually a situation where you should not get it. So that's another kind of point to make about that.
Right, so we're winding down the time here. We haven't really talked about resistance mutations. Most of us have heard of G2032R, and that is the most common, and we have some drugs that are trying to target that. But how about the other resistance mutations? Can you talk about how to treat those?
So there are several mutations in ROS1 that have been found to cause resistance, mostly to crizotinib because that's the pill that's been around the longest, but also to entrectinib and other ROS1 targeted therapies as well. I think the simplest way to think about them is that of the ones that we know about, except for a rare couple, ROS1 G2032R is the one that tends to be the most refractory in terms of hardest to cover. So that's why, and most common. And so that's why the next generation ROS1 inhibitors that have been developed have been really developed to be able to overcome that mutation. There are several others that can be targeted effectively by available ROS1 inhibitors, actually. There will probably be emerging new mutations as we get these next generation ROS1 inhibitors that we might hear about, but we have yet to uncover them because next generation ROS1 inhibitors have just recently become available. So I would say in general, it would be helpful to get a biopsy to discover those ROS1 resistance mutations if they indeed exist in your cancer, because that knowledge will help your doctors explore, okay, this is the arsenal of ROS1 targeted therapies that we can help you access either by prescribing them or through clinical trials. Based on the ROS1 mutation that your cancer has, these are likely to be active. Let's talk about those in more detail.
Yeah, I think that's a very good summary. And then we kind of alluded to this earlier about the concept of on-target, off-target, and transformation. So I won't necessarily go into more detail than that. It is going to be very case by case. There are some off-target mechanisms of resistance, such as MET amplification, where we have actually very good pill-based treatments, and so there's a combination of using drugs like the specific patient I'm thinking of that I did this for was a patient was on lorlatinib, and then we added a MET inhibitor called capmatinib, and they got a pretty good response with that combination. There are toxicities with this off-label approach that are unknown, so I think this is where consultation with someone who sees a lot of ROS1 patients might be helpful.
Amy, to address that, he mentioned MET amplification. Would any NGS test pick up MET amplification?
Yes. It's based on yes, is the short answer. Historically, it's been done with an assay called FISH, fluorescent in situ hybridization, to look for amplification, but many pipelines of NGS can also detect amplification based on the sequencing data. I will say when we do get a resistance case in the lab for testing, even if you have a ROS1, we do, yes, there are kind of a finite number of like mechanisms of resistance, but when we do get a resistance case that's ROS1, we do the full panel again, because we want to see what all is going on. Resistance cases are challenging because a lot of resistance mutations are subclonal, so not every single tumor cell is potentially harboring that alteration. And so, amount of specimen and everything kind of plays into what we're able to detect. So we, in the lab that I work, we really do a lot to try to enrich, what we call enrichment, which is just take from that specimen what's purely tumor, because sometimes with any biopsy, there's sometimes just your normal cells can sometimes come along for the ride. And we don't want to waste our sequencing bandwidth on the normal cells because they're normal, they're functioning. We just want to make sure that we're just looking at the tumor cells. So there's a lot of pre-analytic things that can go into play that we can do to enrich, to really strengthen the signal that we're detecting. So I guess I apologize. I should have practiced more before I came to do this talk. But when you do develop resistance, we are looking more comprehensively at what's going on in the tumor cells. It's the short answer.
I think, actually, I have to say, this is a great plug for academic centers because we love getting into the weeds and talking about the granular details and really trying to understand what does the molecular testing say to us, and I think that interaction and that sort of collaborative environment really, helps our patients in a way that you can't necessarily quite measure through some various metrics, but yeah,
I will second that because
we're so delighted to have a molecular testing lab embedded within our institution.
yes, 100%. I really enjoy the nerdy conversations I have. And so much so that we've published a case report that was highly nerdy. So very excited about that.
Yeah, and I will reach out to them if I see something and I'm like, well, I'm not really sure if this is clinically significant, but it's kind of different and cool, and so we can kind of go back and forth about what this might mean and if we,
I love those emails about it's hot off the press or it's not going to be reported yet, but here's the actionable alteration that you can do something about.
The tweet before the tweet.
So I have,
Sorry, that just got me really excited too. I get those too in Boston, and just it could come late at night, close to midnight, and our eyes just light up.
and I guess I will say, even though none of you meet your molecular pathologists or the individuals that are doing your testing, I am so engaged in your care. I read your charts. I want to make sure that what I am seeing and how I am interpreting what I see really makes sense with what's going on with you and your tumor. So I feel like I'm a part of your cancer team, even though I don't see you. So thanks.
this is a plug to hug your molecular pathologist. So I have a general question. Do treatments that work for ROS1 positive lung cancer work for all ROS1 positive cancers?
Yes, it's been my experience. So I have treated ROS1 positive cholangiocarcinomas. I have treated ROS1 positive soft tissue sarcoma. So even though it's most commonly described in lung cancer, the general take-home point is to treat the activating fusion and focus on that. They are exceptionally rare, but they do occur, and they do also respond to therapies. So,
I'm curious, your clinical experience when I've had non-lung cancer patients with an actionable alteration, it seems like the benefit derived isn't as long.
yeah, they
Is that what you've
tend to not have the CD74 ROS1 fusion partner. They have some other fusion partner, and so I wonder if that plays a role. But they do respond initially, so it's not like I put them on this therapy and nothing happens. But you're right. Cholangiocarcinoma is problematic for a lot of reasons. So cholangiocarcinoma is a cancer of the bile duct and the gallbladder. area. And so those just tend to get problematic because they run into issues with infections and recurrent obstruction, and then their ability to clear the drug gets all up and down. So I think that in this patient I'm specifically thinking of was an issue. But we, for example, using another fusion ALK, we have a phase 1 study open, and we have put patients on that who had colorectal cancer, pancreas cancer, breast cancer. So I think my general view is to treat the fusion, and then there might be differences in biology that are relevant. But I think if you do find a ROS1 fusion, especially in something like cholangiocarcinoma, the standard treatments there are just brutal chemotherapy. And so this was an opportunity to give this patient a targeted therapy that the cancer subtype that she has normally would never receive.
Yeah, I would just add, I think this goes to emphasize how going forward it is so important as new targeted therapies get developed that they get evaluated in patients with not just lung cancer, but other types of cancers as well, where the same oncogene driver is shared. We're all only grateful for the advances that have been made with the existing ROS1 targeted therapies for patients with lung cancer, but all of these pills that are currently FDA approved, right, really for ROS1 lung cancer. And so I think there is a movement that we're seeing now with some of these next generation ROS1 inhibitors where patients with non-lung cancer types are being included if they have the ROS1 fusion driver, and that's exactly the direction that we should be heading towards.
Yeah, we can learn from the larotrectinib story with NTRK fusion positive cancers, where they did just that, and they got a tissue agnostic approval for NTRK fusion. So I think that you don't know unless you start looking, and if the only time you're looking is lung cancer for ROS1 fusions, then you're going to find it enriched in just lung cancer. But I think if you go to see Bioportal and you look at some of these kind of larger data sets, you do see ROS1 fusions, and you can speak to this outside of lung.
Yeah, so I guess I'm a little bit naive in terms of what the clinical decision making is if it's like off target. So some FDA approvals for like BRAF are just pan tumor. So if your tumor is driven by a BRAF mutation, then you're a candidate for therapy. In terms of treatment decisions, I'm more removed from that than you guys are. But I know that in some cases, for like compassionate care or something like that, off-label use is used. I don't see a lot of ROS1 fusions outside of lung cancer. That's partly because about half of the tumors that we test in our lab are lung cancers. So if I'm going to see a ROS1 fusion, it's generally going to be a lung cancer case. So that might just be a bias in terms of the types of specimens I'm getting to test.
Well, I think it's also because it's relatively rare. We had a hard time getting people to even test it in lung, and the other cancers aren't testing. So, all right, so I have a question that might fill up the whole rest of the time we have, the 15 minutes. We've mentioned, among other things, TILs several times. What new developments in ROS1 cancer excite you the most? Go.
Yes. This is a plug for the tour of the labs tomorrow. And my collaborators, Rafe Nemenoff and Lynn Heasley, are working to build a mouse model of ROS1 positive lung cancer, which just hasn't been done before, specifically in mice that have a full immune system. So oftentimes when we study cancer in the lab, we either are studying cancer in a dish, which is not really recreating what happens in the body, or we study the cancer in mice that don't have an immune system. And so it's really hard to understand how those immune cells interact with the cancer cells and how that interaction influences responsiveness to therapy. And so being able to talk to them and see how they're building those models, I think is really an incredible part of what's been designed here for this summit. And the reason I say that is more and more, again, so I'm very biased. My lab looks at this in fusion-driven lung cancer, trying to understand how the immune system interacts with the cancers and how we can augment that response. And I think there's a really great unmet need to bring the promise promise of immune-based therapies to patients with oncogene-driven lung cancers. And that's something I'm really passionate about, and it comes through not only in research, but also in my clinical practice in interaction with sponsors of clinical trials, where I really try to encourage them to open up their trials to patients with a broad diversity of molecular alterations. Just because checkpoint inhibitors or the immune-based medicines that we have now in clinic don't work in this particular situation, that does not mean other immune-based therapies don't have an opportunity to work. And the point of contact where the immune system gets thrown off by the cancer is so varied. There's so many ways to augment the immune system that we have to keep trying in all of our patients and the patient subgroups in order to find what works in that situation. So specifically to your question about TILs, yes, I'm excited. Of course I'm excited.
Can you explain what they are?
Absolutely. So TILs, it's T-I-L, it's tumor-infiltrating lymphocyte therapy. And so what happens is that patients with cancer, they have a tumor that's resected, sometimes by biopsy, sometimes by surgery, and what happens is the tissue is processed and the immune cells are pulled out from there and given special activating therapies to cause those immune cells to expand and cause them to become active again. Once those cells have been prepared and there's a sufficient number and activity level, they're then given back into the patient. So a patient comes in, has a tumor taken out, that tumor is sent to a lab to do this processing to activate the immune cells in the tumor, and then they get infused back into patients. The challenge with this therapy is, what do we have to do for the patients to be ready to receive the therapy? Because the TILs require us to make room in your body for those cells. And what I mean by that is you receive something called conditioning chemotherapy, or these are chemotherapy medicines that kill some of the immune cells in your body so that the TILs have space. They have a space for them. There's like a parking spot in the body available for the TILs. So they can be able to infuse into the body, expand, persist, and hopefully target the cancer cells. So that's actually a hospital stay to get these particular chemotherapies. The TILs are then given back to the patient. And after the TILs are given, some very powerful medicines called cytokines are administered several times after the TILs, and they can make people pretty sick. So all in all, what I've described is a really intense therapy regimen. But I think what the important thing is conceptually that we're just learning about in patients with lung cancer is that even if patients have a classic TKI-treated oncogene-driven lung cancer, in the clinical trials we've had so far, those patients have been some of the really profound responders so far that we've seen in a handful of patients that we've looked at. And that gives me a lot of hope that the fighters are there, right? The immune cells ready to go kill the cancer are there. What we need to do is help them get there and help them be active and effective at eliminating the cancer cells.
Anybody else have something they want to comment on what they're excited about?
I have more to say about that.
I bet
but
you do. We have 5 minutes.
I guess I would say from a molecular perspective that you can't see what you're not looking for, and if you don't test for it, you don't know it's there or not. So I am just really enthusiastic about just getting data. And even if we don't know if it can influence directly today clinical decision making, all the molecular complex information that we're getting could potentially inform our understanding in the future. So I am just a big advocate for just having as much genetic data as you can.
I'm really excited about TILs as well, but I think my research interests are sort of a little bit different than Erin's, and I think TILs are amazing. So I want to just plug TILs and then also say what I'm excited about, which is I think one of the central things we've talked about in this conference room is what do we do at the time of resistance? And I've been fascinated with a different question that's sort of orthogonal to resistance, which is So let me ask up, just poll the audience here. So when you started your ROS1 targeted therapy, how many of you on your first scan had something that the doctor could still point at? Like say there was some tumor that was still there. It was smaller, but it was still there on your scans. Right. So what is going on with your cancer at that 8-week time point? Why is it even there, right? We're talking about how amazing these ROS1 targeted therapies are. Shouldn't they all be dead by this point? And the truth is they're not. And we call those cancer cells persister cells. And learning more about persister cell biology, what is it about cancer cells that cause them to adapt to a targeted therapy and then remain dormant? And looking at specific vulnerabilities within that population, I think is going to be the next big advance, because we can learn a lot from actually the funny thing is we're talking about all of this, and our malignant heme colleagues have already done this, right? So if you go to the leukemia world, they're using a drug called venetoclax, and venetoclax is a very specific drug that targets the leukemia stem cell, right? So this is the cell that after you give this super intense chemotherapy, is still around, and then you do transplant, and that's the thing that comes back and provides or causes leukemia relapse. And there was unique vulnerabilities in this stem cell population that was described by some of the people here at University of Colorado, the Paul A lab and the Jordan labs, which looked at there's a specific vulnerability called BCL2. Now, I'm not saying that that's the vulnerability for lung cancer, but I'm saying that that concept and recognizing that BCL2 was a vulnerability in the stem cell population and that there was a targeted drug called venetoclax that could specifically block it has really been a game changer in leukemia in terms of reducing relapse risks in high-risk patients. So I think, to me, that's the thing that I get most excited about, is thinking about how do we figure out what vulnerabilities exist in this persister population, and are there ways we can be even more aggressive up front than just stay on entrectinib or repotrectinib until progression. Like, why wait till progression? Let's do something at the first scan.
Jess, did you have something?
I think these are all exciting. I think the themes that you're hearing echoed throughout this panel session is that, one, checkpoint inhibitors are not all immunotherapy. It's just a small part of immunotherapy, and there's a lot of exciting work going on to galvanize immune methods to have your body be able to recognize cancer and to fight cancer. And I share the hope that we can make that come true for oncogene-driven lung cancer like ROS1 lung cancer. Two, we absolutely need to understand better why there's residual disease at maximal response to targeted therapy, and why do these cancer cells persist, because that's really going to be a transforming event in our knowledge base where we can really advance therapies another step ahead. Three, most of the patients, I bet in this room too, are still being diagnosed with lung cancer like ROS1 lung cancer once it's reached advanced stage, right? Stage 4 metastatic stage. We need to do better. We need to be able to detect it and diagnose it at an earlier stage, so when we can resect it and cure it. And so better diagnostic methods, honestly, has to be a huge emphasis here. And four, I think we're getting to an era with targeted therapies where we are reaching a certain level of efficacy so that we can pay proper attention to the quality of life and side effects. There's been an overemphasis on doing better in terms of effectiveness, because that's so important. Of course, it's critical. But I think now there's been enough advances with targeted therapies where more and more attention is being paid to how are the pills actually affecting your quality of life, what are the side effects that we need to learn to better manage, and so there are more research studies that are being done to that end, and I think that's critical as well.
I will tell you there are still more questions that came in from the audience than we had a chance to get to. I tried to focus on the ones that were specific to ROS1. I did want to point out, Erin mentioned the lab tour tomorrow and that the mouse model that's being built. I want to point out that model is being developed with our seed grant money. So this is why we raise money. It seems like you get a lot of emails and notices in the group about fundraising come fall. But this is why we do it. We need the money to drive the research because there isn't that much research funding out there for ROS1. And if we can put out seed grant money for things that are new and innovative, we might even attract new researchers to the field. Well, this has been an amazing panel. You guys are all great.